diseases. Dr. Anivita did her graduation from Lady Hardinge Medical College and 6 years course of BM Infectious Disease from All India Institute of Medical Sciences, New Delhi. Thereafter, she joined Sir Ganga Ram Hospital. Presently, she is working there as a consultant in Department of Infectious Diseases and Internal Medicine. She has a lot of publication in her name, both at national and international levels. She also remains busy as a speaker in various state and national conferences of infectious diseases. Incidentally, she was one of the 3 members advisory committee in 2022 who provided recommendation to the Ministry of Health and Family Welfare, Government of India regarding management of Mpox. Over to Dr. Anivita to start her presentation.
Thank you so much for this humble introduction. So I am truly honored to be invited in such a prestigious event, and I hope I am able to provide some insight to this upcoming disease, which is seeming like a scare in the recent times. But if we all are aware, if we are all able to pick up this disease in time, we shall be able to manage it well. I hope my slides are visible to everyone.
Not yet. I think you need to share your screen, ma'am.
I'm sorry for the technical error. Yeah, is my screen visible now?
It's coming
yes,
up.
You can go ahead with your
Now they are visible.
Yeah.
Right. Okay. So we shall be briefly discussing about how these monkeypox outbreaks have truly become a cause of concern. What are the clinical features which can help us clinch the diagnosis, and most importantly, if we are suspecting monkeypox, how should we do the sample collection and how should we proceed? Is there any management and prevention that we all must take care of? Just a brief overview. So previously this was referred as a zoonotic illness as it was diagnosed. It was picked up initially from a monkey. However, subsequently as human diseases were identified, in 1970, we had the first case identified from Democratic Republic of Congo. So as we all know, there are 2 clades. One is West African clade and one is the Central Congo clade. So what are clades? These are basically the lineage patterns which are different in certain characteristics. However, they belong to the same virus because of certain mutations happening from year to year. These clades offer different clinical features and different types of disease presentations. So one is the West African clade, that is clade 2, and one is the Central African clade, which is clade 1. So if you go through the history of the disease, initially it was known to be within the research group of monkeys in 1950s, and 1970 it got its attention when the first human case was picked up. After which, over the decades, multiple cases were picked up. However, only in 2003 was the first case outside of Africa that was picked. Here, the history that was taken was very interesting, that this family had some exotic rodents from Africa, from whose close contact the patient was developing monkeypox. After which there were multiple outbreaks, and in 2022 there was a huge global outbreak where more than 50,000 cases were reported and all over the country. So since then, now we are facing a subsequent outbreak. If we get a brief overview about these clades, so what is the difference exactly apart from the geographical location? So the clade 1 is known to be less virulent, and it is the cause of the current outbreak, which is mostly clade 1A. However, clade 2 was the one which was causing the majority of the outbreaks in the previous decades, and in 2022 it was one of the cause of the major outbreak. The human-to-human transmission is more implicable in the clade 1, that is the current outbreak, where number of children are also getting affected more than men, more than adults. And in clade 2, the human-to-human transmission was much less reported. So this is how the lineage, the phylogenetic lineage of the virus spreads. The lower down we can see clade 1, which is the blue, and the upper we can see clade 2, which further diversifies according to the mutations and the characteristics. So as of now, if we look, the current outbreak is clade 1, clade 1B to be precise. And as of now, the children are at a very high risk of developing this infection. Almost 70% cases in Congo have been reported to be under 15 years of age. And the case fatality rate is very alarming. And that is the reason why here we are to talk about this disease. So amongst kids less than 1 year of age, the mortality rate has been found to be as high as 8.6%, which is quite alarming. So if we get an overview of the current outbreak, as of now, more than 1 lakh cases have been reported all over India. All over the world. And more than 10 countries have been affected, including USA, including UK, as well as other European countries. In India, as of March, we had outbreak in Kerala where 27 cases were reported and 1 kid unfortunately died. And we had a recent case that was reported in the news about a couple of days ago, which we will talk about that case in detail later. But from March till now, no case has been reported in India, and there has not been an outbreak or spread in India since then. The cases that were reported previously were essentially restricted to Kerala. So let us have an overview about the transmission. So how does this transmission actually happen? So the transmission is essentially via multiple insects like squirrels and monkeys and dormice. However, the reservoir is not clear whether these ones actually have the virus transmission through the reservoir. Animals to human transmission is via close contact from an infected animal, bites and scratch of these animals, or even going for hunting and having infected meat. So hence, human transmission to human transmission is what is our cause of concern. So respiratory droplet is one major mode of transmission. That is where most of the kids end up acquiring the infection. Vertical transmission, and most recently that has been contracted, is the inappropriate sexual behavior, or the MSM population has been found to have a lot of transmission amongst their community. Additionally, something similar to how we recognize chicken, we can consider this to be a very similar mode of transmission in terms of fomites. So contact with contaminated items which has the lesion secretions from the lesions, beddings, clothing, and respiratory droplets. So these are the most common modes of transmission if we look at kids. How does this actually occur? So to describe via the respiratory droplets, the contaminated surfaces, and these mucocutaneous lesions, the virus enters the body, where some amount of prodromal symptoms can end up happening. But usually, as the primary viremia is followed by lymphoid organ transmission, some lymph nodes can be enlarged, after which comes the secondary viremia. Usually, the prodromal stage is more predominant in this secondary viremia phase. In the secondary viremia, now the virus spreads to multiple organs as well as to our skin, where the rashes end up starting to develop. This incubation period can last for a total duration of 7 to 21 days from the mode of index presentation or the mode of contact. If you look at the clinical features, so the prodromal symptoms last for approximately 4 to 5 days, and they can be in the form of fever, they can be in the form of lymphadenopathy, which is one of the most characteristically differentiating feature amongst all its differential diagnoses. We'll be discussing that. Headache is another predominant feature, with myalgia, severe fatigue, backache. Rashes usually last for approximately 1 to 3 days with the fever onset, and it lasts for approximately 2 to 4 weeks. Like we see the fever pattern in chickenpox, usually the rash comes within 24 hours. However, in monkeypox, the rash can come as late as 3 days from the fever, and it lasts for a longer period of time. The infectious period, which is the most important for us in terms of counseling our patients, is 1 to 4 days before the appearance of rash, and till all the rash is completely crushed off and the new skin is formed. However, in the recent outbreaks, we are finding certain atypical presentations, which we must be aware of. What are these atypical presentations? So the prodromal phase might not always be there. The rash can begin from the genital areas rather than the classical presentation. And other than the rash, features like proctitis and perianal skin lesions have also been found. So if we look into the clinical features, the most common is almost 97% of the patients will have rash and almost 60% patients will have fever. Uh, Additional to that, myalgia, chills, pruritus will be seen in approximately 50%. And a few patients have also presented with conjunctivitis and proctitis, like we discussed. So this was the recent outbreak. This was basically from an abstract presentation from the recent outbreak and the atypical presentation. So if you can see, this is the classical rash, which we'll be discussing in a few slides. This is how the genital rashes look like, which can be very similar and confused with other STDs also. And some amount of proctitis can also be seen in a few patients. Urethritis, and I would want to take your attention to this pharyngitis ulcer. As you can see, this kind of an ulcer and pharyngitis can be seen in usual tonsillitis also. But in case of high index of suspicion of travel history, epidemiological history, we must investigate this further. Conjunctivitis can also be present with lymphadenopathy, and superadded bacterial infection is a dreaded complication. So as of now, if we look from the WHO report, we have mostly seen that the outbreak is in adults, and confirmed cases have been mostly men who've had sexual contacts as men having sex with men. And in the last 6 months, the maximum reported cases have been amongst people with known sexual encounter with another person with a rash. So what is the distribution of the rash? So the number of lesions can vary from few to thousands. And there is a centrifugal distribution. That is, that the rash will be starting from the face, and then it will be soon traveling to the rest of the body, and it can be coming to the palms and soles also. Inner genital rash is another clinical feature that is mostly seen in MSM population. However, if we look at the pediatric population, we might not be having anogenital rash. We might be having pharyngeal and orofacial rashes coming to palms and soles. So what are the characteristic clinching points of this rash? How is it different? So this rash is deep-seated. That is one important aspect. It is vesiculopapular. It can often end up having umbilication. But one of the things that we must look for is enanthem that can be present in the mouth, like we saw previously. So the rash can evolve over time. Within the span of 2 to 4 weeks, it will be evolving as macules, papules, vesicles, pustules, crusting, followed by hypopigmented healing. This evolving pattern is something similar to chickenpox. However, the deep-seated nature of the rash is what makes this a little different. So the oral enanthem, which I was talking about, and the pharyngeal lesions, these are the few pictures in which we can see an oral ulcer and tonsillar exudate. So these are the lesions which are there in the palms and soles. These are macules that can be seen on hand and finger. And these are the multiple evolutionary stages of vesicles and papules. Vesicular rash, papular rash, and various other lesions. So this is another genital lesion picture. So we have various differential diagnoses when it comes to fever with rash. And let us quickly go through each one of them and how we can clinch our diagnosis to the very best of our abilities. So the most similarity, obviously, monkeypox holds to is with smallpox, which has been eradicated. So it was known to be a milder version of smallpox. But as of today, our biggest and the most closest differential is going to be chickenpox. So how can we differentiate? Chickenpox may, so we will see crops of lesions coming in varicella. However, in monkeypox, these are known to be synchronous. Monkeypox, the recent epidemic has shown lesions to be as less as 5 to 6 lesions. However, in varicella, they will be florid and the body will be full of them. The distribution will start from the face, whereas in varicella, it will be more from the trunk. And usually in chickenpox, we will not have palms and soles involvement. So this is one more clinching point. Additionally, lymph nodes and the deep-seated nature of the rash is what is different. Hand, foot, mouth disease in pediatric population is a very close differential because it will involve palms and soles. However, hand, foot, mouth disease is non-pruritic and monkeypox rashes can be pruritic. Additionally, hand, foot, mouth disease rashes can be more localized. However, monkeypox can be all florid from face to centrifugal appearance. The rash in hand, foot, mouth disease, as you can see, is an erythematous base with a small vesicular or pustular rash. However, in monkeypox, these are going to be big, deep-seated rashes. Herpes zoster will have a dermatomal distribution with predominant pain, and the rashes are going to be superficial. So this will not be a very difficult differential from monkeypox rashes, so which causes these maculopapular nodules. So these vesicular lesions which are seen in monkeypox will not be common in secondary syphilis. Trunks and extremities might be involved in both. However, the rashes again is going to be deep in monkeypox. However, it will be nodular in secondary syphilis. But this could be a close differential in sexually active population with where we are suspecting STDs. Hence, we should make sure that we are evaluating the patient for both. So what are the complications? Why is it considered to be such a dreaded disease recently? So the complications are multifold, involving almost all organs. If you look at the neurological complications, there have been reported encephalitis and seizures, cardiovascular complications like myocarditis and pericarditis, and even cardiogenic shock have been reported. Additionally, gastroenteritis like simple proctitis, procticulitis, especially in MSM population, has been noted. And conjunctivitis and corneal ulcers with keratitis have also been reported. But hands down, the most common complication is secondary bacterial infections on top of those skin lesions. So if you look at this recent NEJM publication, which gave us a beautiful description of the patients, so one of the biggest challenges of managing patients with monkeypox was superficial secondary bacterial infection and pain. So for severe anorectal pain, these patients had quite a lot of difficulty. They had decreased oral intake. They also had AKI and myocarditis, which required hospitalization and close observation. This was one patient which was with advanced HIV, and this patient had a low CD4 count. However, these lesions were very florid, necrotizing, horrible skin lesions with lung involvement and secondary bacterial infections. If we look at monkeypox in pregnant women, there have been reports of very high cases of fetal mortality, almost as high as 50%, and other complications of pregnancy such as miscarriages and stillbirth. These have been reported in the recent 2022 to 24 outbreaks. So coming to the diagnosis, now that we've figured a basic presentation characteristics, how do we diagnose and whom to send and how to contact? So first and foremost, our probable case or a suspected case is going to be a patient who's had a travel history. As of today, when the disease is not coming in big clusters in India, our epidemiological history has to be the most common clenching point for the diagnosis. So history of travel to any of these countries where currently the outbreak is ongoing in the last 21 days, that is our incubation period, with an unexplained rash, with any of these systemic features is going to be a suspected case. That is lymphadenopathy, fever, body aches and myalgias, and profound weakness. However, a probable case is just going to be the one with an epidemiological link. And a confirmed case is going to be the one in which a PCR test has come out to be positive. So suspected cases is what we need to keep an eye on as of now. Currently, we do not have any serological diagnosis. So how do we diagnose? Either we have PCR testing, which is based on these probes. So how do we go about it? We have to take 2 samples. So we have to take a swab, like how we took a throat swab and a nasopharyngeal swab in COVID. We take any Dacron swabs. We take 2 of these and we take a specimen, vigorously rub it over the lesion from 2 specific separate lesions. Now, before the swabbing, obviously we have to perform hand hygiene. We have to take our PP and we have to take our precautions very seriously. After taking the swab, we have to break it and we have to put it in a clean, sterile vial. So here a VTM vial or the viral transport media is not indicated. We can just send it in a dry, sterile container like a falcon tube. And we take the second lesion also and we put it in another package. We label it well and we have to transport it. So where do we, a few more sites. In patients who are asymptomatic, oropharyngeal swabs can also be sent. Here, oropharyngeal swabs have to be sent in viral transport media. A urine sample and a blood serum sample. This is essentially for research purposes. So in asymptomatic contacts, NIV Pune have directed that they are subsequently planning on performing vaccine studies and research and antibody or antigen assays for rapid detection. Hence, they are advocating to send all these samples for research purposes. But in symptomatic adults, the lesion fluid is what we need to send, or the scraping for the lesion, and additionally an oropharyngeal urine and a blood serum sample for, again, research purposes. So our diagnosis is based on a rash. Blood testing is not recommended for the diagnostic purposes, but for research purposes. Additionally, as we are seeing a lot of MSM population and a lot of STDs, so an HIV testing and a thorough STD screen is warranted for these patients. So how does the form that NIV Pune is distributing? So they would want a detailed history, epidemiological as well as contact history, and a detailed history of full details of the rash. What are the laboratory sites? So here I have enlisted the few laboratory sites which are actively performing monkeypox testing other than NIV Pune. As we can see in Delhi, we have All India Institute of Medical Sciences, which is performing studies, and and additionally, we can directly send the samples to NIV as well. So how do we need to go about it? We will, first and foremost, we need to isolate the patient. We need to provide supportive care. We need to suggest antivirals. And we will be discussing about the immunoglobulins and post-exposure prophylaxis. What can be done? So first and foremost is symptomatic management. The skin rashes have to be kept clean. We have to keep them covered so as to not to spread the disease. We have to prevent scratching. The genital we advocate its bugs. Local emollients, Vaseline, jelly, coconut oil, whatever causes soothing to the ulcers is also advocated. Do we have any promising antivirals? So there are currently 3 antivirals which are the talk of the town. Tecoviriman, which is an antiviral inhibitor of the envelope proteins, Cidofovir and Brincidofovir, which we also use for CMV infections. And so let us have a review on them. So Tecoviriman, this one has been FDA approved. However, there are no RCTs as of now, but this has been tried in smallpox. Hence, by extrapolation, this is supposed to be working well. So this is indicated only in severe disease. What do we mean by severe disease? This is hemorrhagic disease with sepsis, with encephalitis, with multiple sites of involvement, and with any patient who is requiring ICU stay. So there have been various clinical studies and systematic reviews. They have found that in a subset of patients, maybe the efficacy is very inconclusive. It might be having some benefit, but a proper good virological control has not been documented yet with this drug. It has not been approved in kids less than 13 kgs, and it has various drug interactions and side effects. Most dreaded complication is rhinotoxicity. Cidofovir is something that we use for and it has been indicated for the diseases progressed by this particular drug. It is contraindicated in first trimester of pregnancy. However, it can be administered in one analog of Cidofovir, which has less complications. Cidofovir and Tecoviriman, unfortunately, is not there in India. These drugs remain a major actually recommend anybody who has come in close contact with these patients protective measures or a mask or gloves is supposed to be offered post-exposure prophylaxis within 4 days to prevent the disease, and within 4 to 14 days to reduce. So what do we have left in India? Ultimately, prevention. So prevention is our best possible strategy, as these post-exposure prophylaxis vaccines or immunoglobulins are not available currently. So what are the other things that can we do? We can do something like the contacts. This interactions with. So there are multiple vaccines which have become the talk of the town. The modified vaccine, this vaccine, this has been approved, and it is supposed to be working. Mass administration and preventive preventive exposure vaccination for travelers has not been recommended by WHO. That is very important for us to know. So let us have a word on this Genuous vaccine. This vaccine does not have much data on kids as of now, and the peak immunity appears after 2 weeks of administration. 2 doses of vaccine are supposed to be administered either as post-exposure prophylaxis or as places where there has been a major outbreak. However, these are not available in India. So ultimately, what are the precautions? Just like how we did in COVID, we can wear gloves, we can wear eye protection, and we can wear N95 masks while entering into a patient's room. CDC also recommends hypochlorite solution cleaning of high-touch surfaces. So standard contact precautions and droplet precautions should suffice. N95 mask is only when we are coming in close contact and taking samples of the patient. Other than that, this is a very hardy organism. It can survive in various surfaces for months and weeks. Hence, surface cleaning is important. Clothing is important. Clothing cleaning is very important. And other than that, disinfectants for surface cleaning is important. So these are the usual do's and don'ts which we can advocate to our patients if at all. Now, isolation has to be performed until all lesions are crusted and a fresh layer of skin has formulated. So to conclude, as of now, we have clade 1B, that is, which is the current outbreak, which has various different clinical features, which has been found to be more in MSM population. However, kids are being struck with this with a high fatality rate, so high index of suspicion is important. Being a fever with rash, we have to make sure that we have ruled out all our differentials, and linking in epidemiological history, we have a high index of suspicion, and we call the authorities. Precautions and isolations are mainstay. So just a few words on the recent patient which happened to come a few days ago in the news. So this patient had traveled from USA. He's an adult and he's a homosexual, having multiple relations and multiple partners since the last 1 month in various countries. He had traveled from UK to China and then come to India. This patient also ended up having multiple other STDs. So he presented with a genital ulcer, which were multiple vesicular ulcers, which were painless and which were in different stages of vesicles and papules. So as soon as this patient had presented to Apollo Hospital to one of my colleagues, he notified LNJP Hospital, and from there the zonal officer who is in charge of monkeypox ended up transporting the patient, kept the patient in isolation over there at LNJP Hospital. So as clinicians and physicians, what do we have to do? We have to immediately, as soon as we get a suspected case with a good epidemiological risk, we need to either inform authorities in LNJP or in Safdarjung, where they will take the matters into hand. However, if we need to sample, as I suggested, we can take swabs only with full precautions, and we can send them to AIIMS or to NIP Pune. So thank you so much for inviting me. I hope I did justice, and I'll be more than welcome to take all the questions and queries.
Thank you so much, Dr. Anvita, for this really informative talk on monkeypox. I request our chairpersons to please give their 2 cents about it. I request Dr. Tapisha to please speak her mind about this topic and give us your views on monkeypox.
Yeah, sure, Ritika. It was a pleasure to listen to you, Dr. Anivita, and wonderful talk. And I just had a few small queries. For example, for the sake of all the pediatricians who are here and listening to you, suppose a child comes to the clinic in the coming next few months, in whom there is a history of travel to one of the countries where mpox is happening, and the child has a rash on the face and palms and soles. What should I immediately do in the clinic? Should I wear a mask, make the child wear a mask, cover the lesions, and who to inform?
Right. So, ma'am, like I said, this is droplet infection. So, the parents, the child, if possible, and yourself should be wearing a mask. And if you have patients in your reception area, other families in your reception area, they should also ideally wear a mask. If you are examining the patient, then make sure that you're wearing gloves. A mask can be a triple layer mask, but preferably an N95 mask should be used. So as of now, as LNGP and Safdarjung hospitals are the main zonal centers as per the government advisory, so we need to call up the hospital emergency, and whoever doctor is in charge at that particular point of time will be further forwarding your call to the zonal coordinator over there. They will be telling us the process. So as of this patient that I'm talking about, the recent patient who's come positive, my colleague ended up calling the emergency, where the zonal coordinator came in a van with PPE and all this material and took the patient, like literally took the patient. So it caused a lot of panic and scare. So first and foremost, you will have to console the family members and tell them this is what is going to happen, and as well as the patients who are there in the waiting area, that they should take precautions if they came in contact. So the testing as of now is being done by these hospitals, either LGP or Safdarjung, but later on, subsequently, if the testing has to be done from our end, then we'd be performing it the way I said. Additionally, we would want to get all the basic blood workup done for the kid in terms of complications and other differentials as well.
I think RML and Sucheta Kriplani have also been added to the list yesterday. You may check once again, in addition to Safdarjung and LNGP.
Right, okay. I'm not aware of that. If that is so, yes.
And another query, many of us who are above 50 have received the smallpox vaccine. Does that give any protection against severe disease?
Smallpox vaccine is known to have some beneficial effect. However, it may not really prevent the disease from happening, but yes, the severity might be there. These are speculative. We don't have robust data to explain it as of now, but yes, it is likely to cause some amount of cross protection as well.
Yes, so I think there is some data which says that it may protect from severe disease, but it's not going to give you total immunity. Is the Jynneos vaccine being used in Africa?
Yes, ma'am. So it's being used, but the vaccine is having its own set of side effects and complications as well. So it is being used as post-exposure, but because Africa is a poor country, so they're requiring a lot of funding to avail these vaccines. So it's not been really given rampantly, but yeah, they're trying to vaccinate as much as possible.
I think cost is very high. Cost is also, I think, $150 per dose. 2 doses are required.
Yes. So they're trying to pool in some UN funds and UNESCO funds to get this vaccine available to them. But not everybody is being able to get vaccinated.
At present, do we have a stockpile in our country, or are we sort of manufacturing it or something?
No, ma'am. So that is why NIV Pune is requesting that we all send urinary samples and serum samples additional to the usual scraping of the vessel of their own. So that is still under research, that is not yet there. Not really captured any cases recently, but they are in the process.
As far as I'm aware, I think Tecovirimat is not available, but Cidofovir is in our country. Am I right?
whenever is available, we often use it for CMV
Yes.
viral infections post-transplant patients. And even
Adenovirus.
yes, ma'am. Brincidofovir is not available, but we often there have been few cases where from the black market we are able to arrange it for our CMV patients. However, it is very expensive, and cidofovir has its own set of side effects, especially renal complications and nephrotoxicity. And cidofovir also is contraindicated in kids with low weight. So it will not be a very wise choice to give it unless we are pushed to the wall where we have a lot of complications and the patient is pretty sick. Till then, we should save its usage.
So it was lovely listening to you, Dr. Anivita. It was very enlightening. And I think the only concern that we have with Mpox right now is that the clade 1B is affecting a lot of children, and there are a lot of pediatric deaths. The case fatality
Yes.
rates are much higher
Right.
than the others. So we just hope that it gets controlled, the outbreak gets controlled and doesn't reach our country. And over to Dr. B.B Aggarwal, I think my co-chairperson, if he has any questions, or if there are any questions in the chat box.
I think I don't have a specific question. I think one question she has already answered, how to differentiate from hand-foot-mouth disease. I think Dr. Abhishek Kishore, I think you must have joined late. She has already discussed in detail how to differentiate. You would like to listen more? Anivita, can you repeat how to differentiate from
Yeah.
hand-foot-mouth disease?
Right. So, hand-foot-mouth disease is going to be a very close differential to monkeypox in terms of rashes on our palms and soles and rashes on face. However, so monkeypox rashes are going to be more deep-seated and nodular, whereas hand-foot-mouth disease, we have very superficial erythematous lesions. The other differential is monkeypox is going to have a lot of lymphadenopathy. Monkeypox is going to have rashes which will be there on the trunk and other parts also, like in genital area maybe. However, in hand, foot, mouth disease, that will not be possible. So it is one of the close differentials in pediatric population, definitely.
Thank you.
I think there's another
question?
query. Yeah, transmission, regarding transmission.
Yeah, so transmission, like I said, is going to be there either via these infected animals, the ones who are going out hunting and eating raw meat, or the ones who are eating partly cooked meat. Other than that, human to human transmission. So there is vertical transmission from mother to child. There is droplet transmission from secretions and respiratory secretions of the infected person, just similar to chickenpox. Fomite transmission from the vesicles. So the linen, the clothing, and all the patient's beddings are considered to be infective. And other than that, sexual transmission. So sexual transmission, there's a whole theory that it is not really via the semen. The sexual transmission that we are seeing in MSM population is essentially close contact among this community. And it is also rubbing of these lesions and mucosal spread to the genital area. So that is another mode of transmission.
So I just wanted to share that I think there's very good data that secretions, body secretions, cause transmission through either sexual contact or non-sexual contact through fomites if it's an infected bedsheet, etc. And there is a query on respiratory transmission also, because suddenly in USA you found cases who had never traveled to Africa, and all of a sudden these cases were there. So there was some doubt, and there is some data on respiratory, but it's not very clear, right? Not very clear data on respiratory transmission, but there is query that there is some problem.
So the virus isolation from fluid secretions of patients have been found to be there, but how much is it actually translating to human transmission? What bulk of it is, that is unclear. But theoretically, it is possible to have transmission via there. But the US and Africa, the thing that you're talking about, ma'am, has been mostly via exotic animals.
There is also transmission from humans to animals also. Few data are also available. Transmission from humans to animals.
They've taken up.
And so since monkeys are not the only animals involved in the chain of transmission, I think we call it Mpox, not monkeypox, because there are so many other rodents, squirrels, etc., which could be part of the transmission chain, right?
Right. So the name was changed because initially it was from one of the research monkeys, from monkeypox to mpox now, because it's not just restricted to monkeys, to other rodents, and it has fair share of human to human transmission as well. That's why the name has been changed now.
Very enlightening talk. Over to you,
Yeah.
Dr. Ritika.
Right. Thank you so much, Dr. Anivita, for this really informative talk. And thank you to our chairpersons, Dr. Tapisha and Dr. Aggarwal, for giving their insight as well. A very, very big thank you to all the delegates who could take out time on a working day afternoon to attend this meeting and making it successful. On behalf of the team of BLK Telepeds and IAP Central Delhi, I extend a thanks to everyone and a very good afternoon. We'll be coming up with another topic that interests all the pediatricians in 2 weeks' time. Thank you so much and have a lovely day.
Thank you.
Thank you.
Thank you so much. Thank you.
Thank you.